So let me start because it's a success story. What is the Oxford Dictionary definition of success? It says it's an accomplishment of an aim or a purpose. So I would not actually qualify for this kind of a session because we have not yet reached our ultimate goal or aim. But at least the first part, we are being able to see if there is a feasibility testing has been done. So I would just like to share that part of the story with you. And success is always elusive because once you get something, you always want to achieve more and more and more. But let me tell you that this has been a wonderful journey because along the journey we learn a lot of things. And that itself makes you grow, makes you live, meet a lot of different people from a lot of different walks of life. Because as doctors, we are already, into one area where we are so tunneled and we are so focused in our field that we generally have very, very little interaction with other people. So, before going into the future, I would certainly want to, what we are doing now. We should know what we are doing now. We should also throw some light on what we have done in the past before we get into the future. So the question that Rohan asked, am I the right person for this job? So it's just a brief introduction. I've been a GI surgeon practicing for 22 years. I trained myself in general surgery in the late 80s. My teacher is sitting here, Dr. Vasant Valu. I was at the VS Hospital. At that point of time, there was mostly open surgeries being done. Laparoscopy was not even introduced into clinical practice. And then I had my specialty training in GI surgery at AIIMS and Lucknow. During those 5 years, we were just beginning the laparoscopic era. Laparoscopic keyhole surgery had just started, this new technology, high definition. There was no high definition, but it was a CCTV camera. You are looking at the monitor and then you are doing keyhole surgery. So those things had just started. So we trained on laparoscopic surgery for basic procedures like gallbladders. And then 2000 onwards, we developed more and more advanced laparoscopic procedures, and today we're doing almost everything, even all the GI cancers and all the major surgeries by keyhole surgeries. So very rarely we have to open the abdomen for doing procedures. So we have reached that stage, and recently we also embarked on the program of robotic surgery. So this is the current, this is not the future of surgery. Now, this has been the era of open surgery where there were large scars, ragged incisions, large scars which used to cause a lot of pain to the patient, delayed recovery in the long term, wound infections, wound hernias, and several complications related to adhesions of the bowel also. All these are significantly reduced with the adoption of laparoscopic surgery where the pain is reduced significantly, the recovery has improved. There are multiple holes on the abdomen through which one of the holes, the laparoscope or the telescope goes in, and several others, the instruments go in to perform surgeries. So currently I can say that surgery has become very precise because of the precise diagnosis that you can achieve by several beautiful imaging systems or the imaging, diagnostic imaging that has developed by CT, MR, PET scans. We have much better molecular genetic markers for precisely diagnosing patients, the condition. We have much better anesthesia, very, very beautiful agents which are very short acting, wonderful monitoring devices. We monitor stroke volume, bit-to-bit cardiac output monitoring in the theatre for major surgeries. We, because of minimally invasive techniques, the patients recover much early. We use a lot of energy devices during surgery, ultrasonic energies and vessel sealers, monopolars, bipolars, so that the blood loss during the surgery is almost reduced significantly. And we have excellent post-operative ICU care today. So we can take up high-risk patients who are 90 years old, undergoing cancer surgeries, and if they develop post-operative complications because of the good ICU care, we can manage these patients much better. And all this has contributed significantly to making surgeries much more safer in the last 10 to 20 years. Along with this, the newer technologies which have developed have helped us, science, evidence, a lot of research, guidelines, has helped us to practice evidence-based medicine and multidisciplinary care, taking patients being taken care by a team rather than an individual person has improved and made surgery and outcomes much more safer. So today we are sitting there and looking at the future. As I see the future of surgery is what is called as a scarless surgery. That's where everybody wants to go. If you ask a patient if you can get a surgery without having a scar, wonderful. I mean, anybody would like to want to have that. Why would you want a scar to have a surgery? So that's ultimately the future of surgery. That is what I believe. So from laparoscopic surgery, we are moving towards scarless surgery, and scarless surgery are of different types. One of the types is called SILS, that is single incision laparoscopic surgery. So basically what we do is we put just one hole within the umbilicus, and then we do multiple ports from the umbilicus and then doing the procedure. So it's essentially, it's not a truly a scarless surgery, but it can be called as a virtually scarless because the scar is hidden in the umbilicus. It is not seen. So this is what is called a SILS, or a single incision laparoscopic surgery. So here, most of the times, is a naval incision, a small incision, and from this, multiple instruments go in. It was developed well in the last decade. We do quite a few surgeries by this technique. It is a technology, it is a platform which is very similar to that of nodes. But there are a lot of difficulties because the vision and the instruments go parallel to each other. And that's why to do the procedure, there is some difficulty. It's not as easy as in a traditional laparoscopy, where the instruments are quite far away and we get a good triangulation to do the procedures. So we have developed some specialized instruments like curved instruments to do the SILS operation. So these are some of the innovations that we have developed a lot of new SILS and nodes ports. And the person who has developed these prototypes is sitting there here. So we have developed a lot of prototypes for newer generation SILS ports also. So there have been some rigid platforms available, there are some flexible platforms available, and we have also developed some of the different platforms for this. But the actual future of surgery, of scarless surgery, is a truly scarless surgery, and this is called natural orifice surgery. So there are some natural orifices available to us, and if you can do these procedures through these natural orifices, like one is the oral cavity, the transoral techniques. Another is, you can go in females, you can go through the vagina and do some vaginal procedures, and transvaginal cholecystectomies have been performed more than 10 years ago. So this is already well established route. And another is the transanal or the transrectal approach. We can go through these body cavities, into the body cavities, and perform different operations. And this has not been new. Actually, the evolution of nodes started in 2004, and the first nodes procedures like appendicectomies and cholecystectomies going from the mouth and through the anal canal and the vagina have been published from India. So India has taken a lead in development of nodes procedures, and lots of scientists, engineers, and companies work on these kind of new, devices, new inventions to develop nodes. Today, after 15 years, I can tell you that nodes has not developed, it has not become a clinical reality. And there are only rare cases of nodes being reported at the moment around the world. And when we did the failure analysis, why 15 years, so many world's best companies work so hard, the world's best brains work so hard, why this has not developed? We believe that we came to a conclusion that the platform that we used was a flexible platform, and it has its own limitations. The instrumentation itself has its own limitations. There are some novel access routes which were used, which were not routinely used, like vagina and anal canal to enter into the abdomen, and that created some new infections and new problems. So basically, the flexible endoscopies, which we are also doing mainly for diagnosis and a lot of therapeutic procedures, have their own limitation when it comes to performing major surgeries like appendix, gallbladders, hernias. Then there are problems because there is a lot of limitation. The vision and the instruments come in the same channel. It's called the coaxial vision. So when we move the vision, the instrument also moves. So that was not conducive to performing different operations. And of course, the instrument channel was single, so you can't do switching with this kind of flexible platforms. And the manipulations are very limited because the torque of the instruments cannot be applied that properly. And specialized endoscopes devices were used, which are very, very expensive, and it required very high specialized skills and a combination of endoscopes. So some of the companies have developed this kind of very specialized endoscopes to perform special procedures, but they are exorbitantly expensive at the moment. So and at the same time, there were some developments in the last few years of nodes being developed on rigid platforms. And this was one of the platforms, transanal surgery, which was being done for many years. But on this platform, a new procedure for rectal cancer developed in the last about 5 to 7 years. And this was called the transanal TME for rectal cancers. So 2010 to 2015, there were few case reports in the literature and for using this for performing cancer rectal surgery. And in 2016, I went to Mount Sinai Hospital in New York to learn this procedure. And during that period, I developed this idea whether if we can do a similarly transoral rigid port we can develop and do some surgeries. This was a very wide idea because nobody has done this ever in the past ever in the medical literature. So with this, I came back and I started thinking about it. On the first night, actually for the whole night, I could not sleep. All the flashes of the procedures which we could do with this flashed in my mind. So it was an intense desire to develop something. And I think with a combination of our experience in SILS, transanal surgery and flexible endoscopy, I thought we could put everything together and develop something of a very novel, something very different which nobody has done so far. So we thought about this is the way we could do some of the procedures in the upper GI tract, which is called transoral surgery, done with rigid ports, not with the flexible endoscopy. And we knew from our past experience, before the flexible endoscopy developed about 50 years ago, that there was this rigid pipe and the upper esophagus and the stomach and the mouth, everything is in a straight line if you can just extend the neck. So this is well known, but no, we have never used it except for, so this was the diagnostic esophagoscope which was used about when we were trainees about 40 years ago, which was being used, but when the flexible endoscopes developed, this was almost been outdated. With this technique, some of the transoral cervical spine surgeries and upper aerodigestive ENT surgeries are being performed at the moment. But nobody has gone down and done any procedures in the esophagus or the stomach by this kind of a rigid endoscope. So with this, we started developing, we designed some ports. We thought that we could put in the telescope, the regular telescope and the regular instruments, and we could bring down the cost of the surgery significantly, and we could do procedures which we could not think of doing by flexible endoscopy systems. And through which there is a telescope and two instruments go. These are, the markings and there's a bevel, so we could work in the wall of the esophagus, and there is a blood introducer at the tip. This is the introducer, and which has a channel. So under vision, we can introduce all these ports to avoid injury. So these were the first prototypes that we developed. Actually, we started working on animals. We had to go to animal facility because there is none here. So we had to go somewhere to do this kind of feasibility studies. This was the first very crude prototype, single instrument. And subsequently, we developed the second prototypes. The challenge is that there should not be any air leak. While we have to do some insufflation, and we have to develop some better and better washers to prevent air leaks. So with this, these are our current prototypes. Basically, these are transoral long ports. They have an air insufflation port, a suction port, and there is an introducer, and there is a bevel. So you can use a blood introducer and with under vision telescopic insertion so that there is no injury. So we did some cadaver animal studies, we did human cadaver studies, and we also do a routine our work on the animal tissues because that's the easiest available in today's world. Ideally, animal facility is the best, but somehow the primate facility now is very rarely available in our country because of the environmental laws. When I was in AIMS, we had an excellent animal facility, private facility. Now it is completely stopped because of all these environmental issues that have come up. And so we developed our own testing facility with a wet lab. We developed, and we have an authorized vendor from which we get the animal tissues, and we can do our testing on the animals. So we have also worked on the human cadaver labs, and there's special soft embalmed cadavers, and these are best for testing medical devices. And in India, as I know, we have gone to Bangalore for 3 occasions at the MS Ramaiah College where they have especially embalmed cadavers. It's very expensive to book this for a day, but still we have tried and managed this, and I've heard that in the AIMS also they have this kind of a facility. So you can actually do surgical procedures which are akin to real operations, except of course they don't bleed. And simulators are not good, but they are good for training and learning, but they are not good for testing of these new devices. So currently we have developed this transoral endoscopic surgeries essentially for 3 procedures. Yeah. And I'll just show you what are the procedures that we are doing. We're doing this very common problem that's called GERD, hiatus hernia, when we do this kind of a suturing and we accentuate the angle of the gastroesophageal junction by taking few sutures. So this works like an anti-reflux barrier. It creates an artificial high pressure zone. The same procedure today we do in laparoscopy, which is called a laparoscopic door fundoplication, which we have tried to do it scarless through the transoral route. I have a short video, but I think time is a constraint, so I would just go ahead. And this is a transoral gastroplication where multiple sutures are taken in the stomach to reduce the capacity of the stomach and this is used for obesity, for weight reduction, multiple interrupted sutures starting from antrum going on to the greater curve, and this reduces the stomach capacity. So, so that is about gastroplication. I could just show you a short video how this is being done. Essentially, we use this, a suturing device because it's very difficult to take sutures inside and tie the knots. So through the ports, these devices go in and they can take multiple sutures in the stomach. You can see at different locations. And then what we do is we take out the thread and tie the knot extracorporeally, means outside the body, and then push the knot inside the abdomen. So these are some of the sutures that you can take from the stomach. I'm sure because of the lot of light, there is a little bit haziness, but these are the gastric groovy. So essentially, it involves a lot of suturing, and our challenge is to develop a good suturing device for this kind of ports. So in the future, we could do esophageal cancer surgeries by these ports. We could do nodes. We can get out of the esophagus or the stomach into the abdominal or the thoracic cavity and perform procedures. Currently, we have applied for patents. We have received an award from GIS. I've done 4 international presentations of these papers at international conferences. We have an institution ethics clearance to do human trials, which we plan to start in 2019 end, or by 2020 we should be able to start human trials. So essentially there is a evolution of surgery. We are getting into the third space, and we are getting closer to nodes with the rigid and the flexible endoscopy. The future is to apply robots on these kind of platforms, transcendental platforms, so that you can achieve much better triangulation, much more precise movements, because here you need millimeter precision, and here is where actually the robotic benefit would come in by making it more flexible tip. We would also want to make it a combination of a rigid and a flexible device, but I'm sure it will need a lot of engineering help. So in this journey, I had a help from the patents by this Vijay Trivedi company. We visited one of the HitCons and got to know Mr. Sri through, and I've incubated at Venture Studio. We see the Nidhi Prayas grant for this. And there was a chance meeting with Professor Premnath, one of the occasions when he come to Venture Studio, where he could guide me and become a mentor to get some help. We actually are in the need of developing good biodesign engineering work for developing good needle drivers, and we have our own animal testing facility, which and a dedicated team at Kaizen Hospital, which helps me for this kind of a journey. So basically, I can only say that so far we have reached the feasibility stage. The product is completely new and novel. It also comes with the technical know-how, because how to take sutures and how to work with this kind of instruments. And of course, with this kind of deep innovations, there is a long way to go, because these are all very disruptive innovations. We take to do more of trials, animal studies before we go to the human trials, and then subsequently the commercial launch is still at least a 3 or 5 year away from now. So it will also require training of surgeons. So I thank you all. It's going to be a long journey, but success in my view is not a destination. It's a journey. You enjoy the journey and learn a lot of things along the path. And then carry on again. Thank you very much.